Welcome, curious minds, to another deep dive. Have you ever found yourself wrestling with what truly separates, normal from abnormal behavior?
Hmm,
It's a foundational question in mental health, surprisingly complex, and it's precisely what we're tackling today.
absolutely.
We're diving deep into a crucial chapter from Psychopathology and Mental Distress, a go-to source for anyone studying this field. Our mission: to distill the most important concepts, trace the wild historical journey of how we've understood distress, and explore the diverse research methods, all while giving you those aha moments without the information overload.
That's right. And the central theme here really is that defining psychopathology is rarely straightforward.
It seems that way.
Yeah, it's heavily influenced by contrasting perspectives, societal norms that constantly shift, and our evolving scientific understanding. What's truly fascinating and often frustrating for students is that even experts in the field frequently disagree on these fundamental definitions.
Attention will definitely see surface again and again.
Exactly.
So let's jump right into the core definitions then. We often hear psychopathology and mental distress used almost interchangeably, but there's a vital distinction. What is it?
It's crucial. Psychopathology, well, it attributes mental distress to an internal dysfunction, like a kind of sickness within an individual. It implies something is fundamentally wrong inside.
Okay, internal dysfunction.
Right. Mental distress, on the other hand, is a broader term. It just means cognitive or emotional upset.
So like everyday stress.
It can be. This distress can be perfectly normal and expected, like feeling upset after a bad day. Or it could indeed be a sign of psychopathology. The real challenge is distinguishing between the two.
Makes sense.
Think about it. Distress over missing your train is one thing. Believing the government monitors you through your breakfast cereal, that's, well, quite another.
Definitely different. To really underscore how blurry that line can be, the chapter gives us some compelling case examples. As I describe them, maybe think about your own reaction. Which ones immediately strike you as pathological and which make you pause?
Good idea. These are really illustrative.
First, we have Jim, a bright university student. He starts hearing voices, believes his professors are spying on him, stops taking care of his hygiene. He gets diagnosed with schizophrenia.
A classic presentation, many would say.
Then there's Michelle. She's 14, intensely rebellious, constantly arguing, breaking curfew, yelling at her parents. Diagnosis: oppositional defiant disorder.
That one often raises more questions.
Next, Sam, 13, assigned female at birth, identifies as transgender. Sam uses new pronouns, a new name, but their parents refuse hormone therapy, mourning their beautiful daughter.
A very complex situation involving identity and family conflict.
Then consider Mary, 70 years old, a widow. Deep grief, depression after her husband's death. She's isolated, can't sleep, lost her appetite. She chooses therapy over antidepressants.
Grief versus clinical depression, another tricky boundary.
Finally, Jesse. He's a 37-year-old black man living in an area with heightened racial tension. He's genuinely worried about police monitoring him, believes they're out to get him. His therapist finds it hard to interpret these assertions.
Right. Is it paranoia or a realistic fear given his context?
Exactly. As you heard those, some might have seemed clearly pathological, while others might even, well, offend you by their inclusion here.
And that's the point.
Yeah, the key insight is this profound lack of consensus, even among seasoned professionals.
Which immediately raises the question, why? Why such fundamental disagreement on what even counts as mental illness? The chapter highlights a really stark contrast between two leading organizations.
Okay.
So you have the American Psychiatric Association, the APA. They firmly define mental illnesses as medical conditions. Much like heart disease or diabetes affecting emotion, thinking, or behavior, for them it's primarily a disease of the brain.
The medical model, essentially.
Precisely. But then you have the Division of Clinical Psychology of the British Psychological Society, the BPS. They take a very different stance.
How so?
They actively caution against the medicalization of everyday problems. They argue that many so-called mental illnesses are often understandable responses to, challenging life circumstances or maybe oppressive social conditions.
Wow, that's not just a nuance.
Not at all. It's a fundamental dispute about the very nature of human suffering. Are these brain diseases or responses to life?
That profound disagreement, I imagine, must shape the entire landscape of mental health professions, right?
It absolutely does. It's why we need to understand the distinction between psychiatry and psychology. Psychiatrists are medical doctors, MDs. They often adhere to that medical model, viewing problems as illnesses needing diagnosis and treatment, often with medication.
Right.
Psychologists, typically with PhDs or CSIDs, focus more on mental processes and behavior. Within psychology, clinical psychologists might lean more towards individual dysfunction, while counseling psychologists tend to emphasize everyday problems, strengths, fostering well-being rather than focusing solely on pathology.
Okay, different training, different focus. And what about the terms mental illness versus mental disorder? Is one more precise or...
Well, both terms really stem from that psychopathology perspective, suggesting something is wrong inside. Mental illness often carries a stronger biological connotation, at least in public perception.
I see.
The DSM, the Big Diagnostic Manual, tends to use mental disorder. It defines it as a syndrome causing clinically significant disturbance in cognition, emotion, or behavior, reflecting a dysfunction in psychological, biological, or developmental processes.
So leaves a bit more room.
Maybe a little. It still implies dysfunction, but it acknowledges psychological and developmental processes alongside the biological. It's still controversial, mind you, but perhaps slightly broader than a pure brain disease model.
Here's where it gets really interesting, philosophically speaking, the concept of harmful internal dysfunction. What's that about?
Right. This model tries to bring more rigor. It proposes two conditions must be met for something to be a mental disorder. First, a mental mechanism has to fail its naturally designed function. That's the internal dysfunction part.
Okay, like a biological part not working as intended by evolution.
Sort of, yeah. But, crucially, the second condition is that society must deem the resulting behavior harmful.
Harmful. So it's dysfunction plus social judgment.
Exactly. The classic and frankly disturbing historical example often used is drapetomania, the supposed disorder of runaway slaves in the U.S.
All right. Chilling.
Yes. This model, in theory, should protect against arbitrarily labeling social deviance as psychopathology. It forces us to ask, is the function truly natural? Is society's judgment of harm itself flawed or oppressive?
But that should feels like a big word there. Who decides what a naturally designed function is? Couldn't that just swap one set of biases for another?
That is the core critique. Critics worry about how fuzzy mental mechanisms are and how social judgments of harm can obviously shift over time or across cultures.
So it's not a magic bullet.
Definitely not. And this leads straight into alternative perspectives, like deviance. This simply describes socially unacceptable behavior without automatically assuming it's disordered.
It's different.
Right. The sociologist Thomas Scheff argued, quite provocatively, that mental illness is often just society putting a label on behavior it doesn't like or understand, calling it deviant, not necessarily identifying true internal pathology. And then there's the powerful social oppression perspective. This attributes mental distress directly to unjust societal conditions, things like poverty, racism, sexism, economic inequality, discrimination.
How does it connect those?
Well, it argues these conditions either cause individual psychopathology through chronic stress and trauma, or they simply produce what gets labeled as deviant behavior as a completely reasonable, understandable response to a tyrannical or unfair system.
Like fighting back against oppression being labeled as a disorder.
Precisely. The chapter uses that chilling image from The Handmaid's Tale to illustrate how oppressive societies can pathologize perfectly normal human reactions to terrible circumstances.
This connects directly to something very current. The chapter discusses this idea of generation disaster. People born between roughly 1990 and 2001.
Exactly. This generation has navigated 9/11, multiple wars, the 2008 crash, the climate crisis, school shootings becoming commonplace, deep political divides, and then the pandemic, all during their formative years.
That's a lot.
It is. Psychologist Carla Vermeulen's research highlights widespread anxiety, depression, and exhaustion among this group. They often feel blamed or misunderstood. They describe this continual anxiety amplified by our hyper-connected world.
It's a vivid, real-time example of how social adversity really impacts mental distress.
It forces us to ask, are these individual pathologies? Or are they fundamentally understandable responses to an extreme, often traumatic social environment? It puts that sociocultural perspective front and center.
So with all these competing ideas and how deeply personal distress is, how do clinicians or researchers even begin to judge what's abnormal consistently? The chapter lays out several criteria we commonly use.
Right, but as we'll see, none are perfect. They're more like lenses, tools for judgment, not hard and fast rules.
Okay, what's the first?
First up is statistical deviation. Basically, comparing someone to statistical norms. If a behavior is statistically rare, it might be deemed abnormal.
Might be.
Yeah, because being exceptionally tall or having a PhD is statistically rare but hardly pathological, writer.
Good point.
The chapter has this fascinating box. Is shortness a disorder? It builds a case for shortness using statistical deviance, social norm violation, like men being imposing, internal dysfunction, hormones, emotional suffering, and then expertly dismantles each point. It really shows how these criteria can be argued both ways.
So rarity alone isn't enough, clearly. What else?
Next is violation of social norms and values, behavior that just goes against societal expectations.
Like breaking unspoken rules.
Exactly. The case of Sarah and Brian in the chapter highlights this beautifully. Their marriage is in trouble because their families had totally different norms for expressing emotion. Sarah thinks Brian is cold. Brian thinks Sarah is crazy.
They're judging each other based on their own upbringing.
Precisely. Labeling the other abnormal based on their own social programming. And historically, this criterion was used to classify masturbation as onanism and, shockingly, homosexuality as a mental disorder until 1973.
Wow. It really shows how culture shapes these judgments.
Hugely. And how norms can change, or how stubbornly they can persist for some.
Okay, what's next? Sometimes behavior just makes other people uncomfortable.
That's the criterion. Behavior that disturbs others. Think of someone facing the wrong way in an elevator or laughing loudly at a funeral.
Yeah, that would be unsettling.
It violates unspoken social rules, causes discomfort. This criterion often sparks that tricky illness versus responsibility debate. Is the behavior due to pathology, or is a person just choosing to act disruptively? It's a big deal in legal and ethical contexts.
Right. The most concerning one for many, I imagine, is when actual harm is involved.
Absolutely. Harmfulness to self or others. This covers maladaptive behavior causing real harm, things like self-injury, gambling away savings, overdoses, abusing others.
That seems more clear-cut.
Often, yes. It's frequently assumed to indicate psychopathology, especially with imminent threats. But the chapter rightly asks, is extreme sports like skydiving pathological harm? Context matters. Most diagnoses do require symptoms to cause significant impairment in life, social, work, etc. The behavior has to genuinely interfere or harm.
Okay. What about internal suffering itself? Just feeling terrible.
That's emotional suffering, excessive unhappiness, depression, anxiety. The Neil and Sharon case mentioned contrast suffering with no clear reason, maybe suggesting internal dysfunction versus suffering due to awful life events, like losing a child.
When is suffering appropriate versus pathological?
That's the incredibly difficult question. It's deeply subjective.
Finally, what about when someone's view of reality seems off?
That's misperception of reality. When someone genuinely believes, say, the CIA implanted microchips in their brain, we'd likely agree they've lost touch with shared reality, often linked to faulty perception or cognition.
But what about less extreme cases?
That's where it gets tricky. The Sarah and Brian case comes back, whose perception of the mother-in-law is correct. And crucially, who gets to decide what reality is? It's most useful in extreme cases like psychosis. But everyday disagreements also involve conflicting perceptions.
So these criteria, helpful tools, maybe starting points for discussion, but definitely not definitive answers.
Exactly. It's always a discussion, always influenced by context, values, and perspective.
To help make sense of all these disagreements, the book organizes the overarching perspectives into three main types. Can you outline those?
Sure. First, you have biological perspectives. These emphasize malfunctioning physiology, brain chemistry, genetics, etc. They tend to view mental distress as medical conditions.
Okay, the body and brain focus.
Second, psychological perspectives. These conceptualize psychopathology in psychological terms, problematic thoughts, feelings, learned behaviors, unconscious conflicts, that sort of thing.
Mind and behavior focus.
And third, sociocultural perspectives. These attribute mental distress primarily to social causes: poverty, discrimination, cultural pressures, family dynamics, social oppression.
The environment and society focus.
Right. And you'll see these three viewpoints constantly interacting, sometimes complementing each other, often clashing, throughout any study of mental health.
It sounds like a constant balancing act.
Yeah.
Now let's zoom out and trace this through history. How did we get here? The chapter covers this, right? It's
Yeah,
quite a story.
it really is, and sometimes a chilling one. We start way back in the Stone Age. There's evidence of trepanation drilling holes in skulls,
Why on earth?
often linked to a demonological perspective. The idea was maybe to let evil spirits out. But
Wow.
you could also see it as a very early, very crude biological intervention, right? Trying to fix something physical in the head.
Interesting point.
Yeah.
Then the ancient Greeks arrived. Things got a bit more
Yeah.
scientific.
In a way, yes. Hippocrates famously introduced his theory of bodily humors. He shifted focus, arguing imbalances in fluids like black bile, yellow bile, phlegm, and blood cause psychopathology. It was biological, though obviously incorrect by modern standards.
And he had some interesting ideas about women.
Ah, yes, the wandering womb theory for hysteria, diagnosed only in women, supposedly caused by the uterus moving around the body. We now see that as, well, pretty clearly sexist.
Definitely. But weren't there other Greek ideas too?
Absolutely. Philosophers like Socrates, Plato, and Aristotle offered more psychological views. They talked about the soul, reason, logic as ways to overcome emotional difficulties. It remarkably foreshadows things like modern cognitive behavioral therapy.
So seeds of both biological and psychological thought way back then. What happened in the Middle Ages?
It really depended where you were. In the Islamic Middle East, thinkers like Avicenna built on Hippocrates' biological views. Early hospitals there actually offered quite humane psychological treatments, bibliotherapy, hydrotherapy, music.
Sounds surprisingly modern.
It does, but in Christian Europe, things largely swung back towards demonological perspectives. This was the era of witch hunts, fueled by texts like the Malleus Maleficarum, the Hammer of Witches.
A dark period.
Very. And you had phenomena like dancing mania, large groups seemingly compelled to dance uncontrollably. It just vividly shows how cultural context shapes how madness looks and is interpreted.
Then came the Renaissance. Social upheaval, a focus on melancholia,
Yeah.
and the rise of asylums.
Yes, exactly. You had places like Geel in Belgium, which started with religious roots but became known for humane, community-based care, integrating people into family homes.
That sounds positive.
It was, relatively. But then you had the infamous Bedlam in London. It became synonymous with chaos, deplorable conditions. Patients were often chained, neglected, even displayed to the public for a fee. The artist Hogarth captured the horror. A real contrast.
Awful. Moving into the 18th and 19th centuries, did things improve? We hear about reform movements.
There were definitely efforts towards more humane treatment. This era saw the rise of moral therapy. Think early psychotherapy.
Who were the key figures?
Philippe Pinel in France famously unchained patients. In England, the Quaker William Tuke founded the York Retreat, emphasizing gentle treatment, social environments, and meaningful activities instead of just confinement and restraint.
Sounds like a big step forward.
It was initially, but critics did argue it could be its own form of social control imposing middle-class values, and moral therapy eventually declined. Overcrowding, staff shortages, prejudice crept back in, and the medical model regained dominance.
And wasn't there a major reformer in the U.S.?
Dorothea Dix, a truly heroic figure, she tirelessly campaigned exposing horrific conditions in existing jails and almshouses where mentally ill people were kept. Her work led to the creation of many state mental hospitals.
So she improved things.
Immensely, in terms of getting people out of prisons. But some historians argue her focus on state institutions inadvertently contributed to the rise of huge impersonal hospitals that later became known for warehousing patients rather than treating them effectively. A complex legacy.
Into the 20th and 21st centuries, things seem to get even more dramatic. Controversial treatments, social movements.
Absolutely. The first half of the 20th century saw mental hospitals reach peak populations. And some really controversial treatments emerged, trying anything, really. Malarial therapy, insulin coma therapy, convulsion therapies like ECT, electroconvulsive therapy, which is still used today but refined, and of course lobotomy, psychosurgery, often used quite desperately.
Then came a backlash.
A major one. The second half of the century saw the rise of the antipsychiatry movement. Figures like R.D. Laing and especially Thomas Szasz powerfully challenged the biological model.
What was Szasz's argument?
Very controversial. He argued mental illness is a myth. His point was that minds aren't physical organs, so they can't be diseased like bodies can. He saw what we call mental disorders as problems in living that society incorrectly medicalizes, often for social control.
That's a radical view.
It was, and still is. This critique, along with the development of early antipsychotic medications, fueled deinstitutionalization, the mass release of patients from large state hospitals back into the community.
The intention was good, right? Community care.
The intention was often good, yes. The idea was community mental health centers would provide support. But often, the funding and resources just weren't there. Funding got cut, services were inadequate. It left many vulnerable people without sufficient support, contributing to problems like homelessness that we still grapple with today.
What a journey. It really underlines that, quote, psychiatry has always been torn between two visions of mental illness. One biological, one psychosocial.
Precisely. That tension is still very much alive.
So, given all this history, all these competing ideas, how do researchers actually try to sort through it all? How do we gain reliable knowledge?
Well, the foundation is the scientific method, systematically collecting and evaluating evidence. But even within that, there are different approaches. Broadly, we talk about quantitative methods and qualitative methods.
Okay, what's the difference?
Quantitative methods use numerical data, measurements, statistics. They aim to test specific hypotheses, often looking for universal laws or patterns. Think numbers, graphs, statistical significance.
Measuring things.
Right. Qualitative methods, on the other hand, gather non-numerical data. Interviews, observations, text analysis. They aim to understand subjective experiences, social processes, cultural meanings. They focus on depth, context, and understanding specific worldviews. Think rich descriptions, themes, interpretations.
Let's dive into the quantitative side first. What are the main tools?
A very common one is the correlational method. This looks at relationships between variables, anything that can change or vary.
Like studying if stress levels are related to sleep quality.
Exactly. You measure both and see if they tend to go together. You might find a positive correlation. As one goes up, the other goes up, like, say, study time and grades. A negative correlation. As one goes up, the other goes down, like maybe time spent worrying and feelings of happiness. Or no correlation.
Okay, pretty straightforward.
But here's the crucial mantra, the one you'll hear constantly. Correlation does not equal causation.
Right. Just because two things are linked doesn't mean one caused the other.
Precisely. There could be a third variable influencing both. Or the causal direction might be the reverse of what you assume. It tells you if things are related, but not why.
Got it. What else in the quantitative toolkit?
A specific type of correlational research is epidemiological research. This studies the distribution of disorders in populations looking at prevalence. What percentage of people have a disorder right now or over their lifetime? And incidence. How many new cases appear in a given time?
Why is that useful?
It's vital for public health. For example, tracking the sharp increase in depression and anxiety incidents during the COVID-19 pandemic helped understand the scale of the mental health impact and plan responses. It tells us who is most affected, where resources are needed.
Makes sense. But if we want to know about cause and effect,
Then you need the experimental method. This is often called the gold standard for inferring causation because the researcher actively manipulates variables.
how does that work?
You start with a hypothesis, a specific prediction. You identify an independent variable, that's a thing you, the researcher, control or change, like giving one group a new therapy and another group standard care. Then you measure the dependent variable, the outcome you're interested in, like the level of depression symptoms after treatment.
And you need groups to compare.
Yes. You draw a sample from the larger population you're interested in. Ideally, it's a random sample, so it represents the population well. Then, crucially, you use random assignment to put participants into different groups, e.g., treatment versus control. This minimizes the chance that pre-existing differences between people, confounding variables, explain your results.
What about control groups?
Essential. A control group provides a baseline for comparison. Often, you'll use a placebo control group. They get something that seems like the treatment but isn't, like a sugar pill or maybe just supportive listening instead of the specific therapy technique. This helps isolate the true effect of the treatment from the placebo effect, people getting better just because they expect to.
And how do we judge if an experiment is good?
Two key concepts. Internal validity, are we sure the independent variable caused the change in the dependent variable? Random assignment and controlling confounds boost this. And external validity, can we generalize the findings beyond the specific study sample and setting to the real world?
Is that often a trade-off?
Sometimes. Highly controlled lab studies might have great internal validity, but poor external validity. For example, relying heavily on undergraduate psychology students as participants, a common criticism. How well do findings from 19-year-olds generalize to, say, middle-aged adults with chronic depression?
Good point.
We also use things like double-blind studies, where neither the participants nor the researchers interacting with them know who is getting the real treatment versus the placebo. This minimizes bias.
You mentioned therapy studies. What are RCTs?
Randomized controlled trials. These are experiments specifically designed to compare different treatments, often a new treatment against a standard one or a placebo. They're considered the strongest evidence for treatment effectiveness and lead to what are called empirically supported treatments, ESTs.
But there's debate there, too.
Oh yes, big debate. Are RCTs the only ethical way to prove a therapy works? Or do their strict protocols miss the messiness, the nuance, the therapist-client relationship factors that are so important in real-world therapy?
Okay, what if you can't do random assignment, like studying people in a war zone?
Then you use quasi-experiments. You work with existing groups. You can't randomly assign people to experience war, obviously. So researchers try to make the groups as comparable as possible in other ways, perhaps using matched control groups, matching participants on age, gender, etc., to reduce confounding variables. But causal conclusions are weaker.
And analog experiments.
These create situations in the lab that are analogous to real-life situations that are too difficult, expensive, or unethical to study directly, like having people watch a stressful film to study anxiety responses, or using animal models like Seligman's classic learned helplessness studies with dogs.
Pros and cons.
Good internal validity, usually, because you control the lab setting, but external validity can be questionable. How much is watching a film like real trauma? How well do dog responses translate to human depression?
And single-subject experiment, just one person.
Yes, often used for rare conditions or to test an intervention on a specific individual. A common design is the ABA design. Measure a baseline, A, introduce the intervention, B, remove it, A, then reintroduce it, B. If the behavior changes systematically with the intervention, you can infer causality for that individual. Useful in clinical practice sometimes.
Wow, okay, that's a solid overview of the quantitative tools. But sometimes numbers don't capture the whole story. What about understanding the experience itself?
Exactly. That's where qualitative methods come in. Their goal isn't usually generalization, but deep understanding of a particular phenomenon, experience, or context.
Like case studies.
Case studies are a classic qualitative approach, in-depth examination of a single instance, a person, a group, an event. Think of Phineas Gage, the railway worker with the tamping iron through his skull. His case provided massive insights into brain function and personality, or Freud's famous cases like Little Hans.
What are the limitations?
They provide incredibly rich, detailed information and can generate hypotheses, but they don't demonstrate cause and effect, and you can't easily generalize from one unique case.
What else is in the qualitative toolkit?
Grounded theory methods. Here, the idea is to develop theories from the ground up, based directly on the data you collect, usually through interviews or observations. You don't start with a hypothesis to test, you let the theory emerge from participants' experiences.
Can you give an example?
Ising's study, mentioned in the text, on parents' experiences with their son's ADHD diagnosis and medication, she found mothers and fathers often had quite different perspectives and concerns, leading to a grounded theory about those differing family dynamics. It involves detailed coding and analysis of the data.
Interesting. And phenomenological analysis, that sounds deep.
It is. Phenomenological analysis aims to describe the essence of a lived experience. What is it fundamentally like to experience something? Researchers try to bracket their own preconceptions and focus purely on the participant's conscious experience.
Like trying to understand what hearing voices is actually like for the person.
Exactly that. Stripping away interpretations and judgments to get at the core subjective reality. It involves deep interviewing and analysis to find the essential structures of that experience.
So quantitative gives breadth and tests hypotheses, qualitative gives depth and explores meaning.
That's a good way to put it. And often the best approach is mixed methods, combining both quantitative and qualitative techniques in a single study to get a more complete, nuanced picture.
Makes perfect sense. Okay, as we wrap up this deep dive, it seems clear that the field of psychopathology and mental distress is really characterized by these ongoing debates, different lenses, conflicting perspectives sometimes.
It absolutely is. And the goal isn't necessarily to find the single right answer that silences all others. It's more about understanding the many valid ways we can approach these incredibly complex human issues. We've looked at definitions, historical shifts, research tools, all contributing to this intricate landscape.
It really highlights how much is still being figured out.
That's right. And textbooks often present what we know with great certainty, like it's all settled fact.
Yeah, they can feel that way.
But embracing the questions, being comfortable with the uncertainty, rather than just seeking the easy answers, that's really a hallmark of critical thinking and true intellectual growth in this field, and maybe any field. It pushes us to a deeper, more honest understanding.
That connects to a final thought we wanted to leave listeners with. Jamie Holmes wrote a piece in the New York Times about ignorance and psychology, basically arguing we should acknowledge how much we don't know.
Interesting.
His point, and maybe ours too, is that recognizing the limits of our knowledge isn't a failure. It can actually open possibilities, not close them. It forces us to keep asking better questions.
I like that. Accepting ambiguity can fuel curiosity.
So we challenge you, the listener. Does recognizing the limits of our current knowledge about psychopathology and mental distress actually help us understand it better? And if so, how? Something to think about. Keep asking those questions. Thank you so much for joining us on this deep dive. We really hope this exploration has given you a robust foundation and, more importantly, sparked your curiosity even further into this vital and complex field.
It's been a real pleasure guiding you through these important and often challenging concepts. Keep reflecting, keep questioning, and definitely keep learning.